Good morning, everyone. My name is Aditya Lati. I'm one of the Grand Rounds directors, along with Doctors Alex Harris and Rebecca Muley. Next week's Grand Round is in honor of Hispanic Heritage Month and will be presented by Dr. Seth Schwartz, Professor of Kinesiology, Health Education, and Educational Psychology at the University of Texas at Austin. The title of his talk is Crisis Migration, Cultural Stress, and Mental Health Among Crisis Migrant Populations. A reminder, if you are participating on Zoom, you can ask your question at any time during the talk. You don't need to wait till the end. Please use the Q&A feature, not the chat feature. And if you're a trainee, and this applies for in the house too, please note when you ask a question that you're a trainee, because we really like to prioritize trainee questions. Today we have a fabulous speaker, but I would not be able to do justice to introducing her. Instead, we have our own Catherine Kate Elkington, who has known the speaker since prenatal times, I think, and would do a far better job. So I'm going to turn it over and let her introduce.
Good morning, everybody. How are we doing? Good. All right. Thank you for the response. Okay. So today, it is my great honor and delight to introduce Dr. Marina Tolou-Shams, who is the Kilroy Endowed Professor of Psychiatry and the Vice Chair for Community Engagement, Outreach, and Advocacy in the Department of Psychiatry and Behavioral Sciences at the UC San Francisco, or UCSF. She's also, because she wears many hats and has a hard time in saying no, she's also the Deputy Vice Chair of Research in Psychiatry at Zuckerberg San Francisco General Hospital, where she focuses on advancing UCSF's public psychiatry research. She is a licensed child and clinical psychologist with training in pediatrics and forensics. She leads the UCSF Juvenile and Justice Behavioral Health Lab, whose mission is to improve behavioral health access and outcomes for youth who come into contact with the juvenile legal, child welfare, and foster care systems. Her lab has a strong emphasis on health equity, gender responsive, and co-designed approaches, and over the past decade has focused on ways to partner with youth families and legal and social service systems in leveraging technology to increase access to care for systems-impacted youth. She has over 100 peer-reviewed publications and has served as principal investigator on numerous NIH grants, including those examining the impact of structural racism on behavioral health trajectories and the implementation of digital prevention tools for foster youth. She's also now the PI of a NIDA K24 Mid-Career Development Award, focused on mentoring early career scholars in conducting substance use research with systems-impacted youth and families. So without further ado, it is my privilege to introduce Marina.
Hi, good morning, everyone. Can you hear me okay? What a treat to be here and to be with Dr. Elkington in postnatal times. We just figured out my oldest is turning 18 in about 10 days. So we figured out that actually, so it's about 18 years. And I'm delighted to be here with you all today to talk about precision justice, harnessing AI and digital health to expand behavioral health care access for systems impacted youth. And so before I get started, and of course, it's always the folks who are doing research with technology that don't know how to use the technology. I just want to point that out. It happens every time. So I have no disclosures or conflicts of interest to report. And I want to first start off with acknowledgements because all of what I'm going to discuss after these slides would never be happening without all of these partners, youth and families, systems, funders. Grateful to the National Institute of Health and Mental Health and National Institute on Drug Abuse, donors, foundations to really supporting this work. And the last bullet point you'll see is my high school English teacher in El Cerrito, California. And I just want to say that I had a high school English project that was pivotal in my quest to advance services in the community for young people who come into contact with the system. And I'm happy to talk about that at a later time. But that's part of my positionality in this work when I was 15 years old and meeting with someone who was formerly on death row to hear about their life and their childhood history and how generous they were. And basically, it was my first real community-led scientific project. So this is our team, part of our team with the Bitmoji, but this is them in real life. We work hard, we play hard, and this is in San Francisco, Golden Gate Park, and in one of our murals in the Mission District where our hospital is based. And the bottom is a group of us at the American Psychology and Law Society meeting last year. So I want to review our learning objectives today. The first being to describe what the term precision justice means and why it's important to advancing youth substance use services access. The second to be, you should be able to explain how rates of youth substance use treatment need are mismatched with rates of treatment referrals for youth in need. And I want to acknowledge that I am here in the home of the JJ Trials group and who has done tremendous work nationally that I've been following for years. And so really excited to talk to you about some more of this work. And the third being to identify one way in which digital health technologies may improve access to substance use services for youth in contact with the legal and or child welfare system. So when I'm talking about systems impacted youth, that's who I'm talking about. Those who come into contact with the legal system at any point, right? From arrest, diversion, all the way through to community reentry from detention, child welfare, foster care. Those are the young people and families. So this is our roadmap for this morning, and I just want to say that this is a scientific tale of innovation, struggle, and learning. This talk is not about perfection. This is not going to be a neat and tidy randomized control trial with 1,000+ participants. This is about community-led, systems-led research and what is involved when we think about the intersection of technology to advance behavioral health care access, and specifically today we're going to talk about substance use and mental health care separately and together. But it really is about what is needed to do this work, and it is messy. I will just give that caveat. I'm going to talk about precision justice, which is a term that I've been cogitating on, developing, thinking about in this space. Systems impacted youth needs. I'm going to give some very brief background on that. Talk about the cascade of care, which again, colleagues at Columbia have been paving the way in this space in terms of substance use prevention and treatment services for youth in contact with the legal system. And I'm going to talk about AI and prevention services access for public sector, which is a very nascent area. So I'm really excited to have discussion with all of you about this space. So when we talk about precision medicine, this full disclosure, this came out of our ChatGPT, that is our UCSF version of ChatGPT in Versa. And when I put in precision medicine, it gave me multiple definitions of precision medicine, but many similar characteristics. So the National Institute of Health defines it as an approach to patient care that allows for more personalized treatment plans based on the individual characteristics of each patient, including their genetic makeup, lifestyle, and environment. World Health Organization, right, has the word tailoring in it. Also individual, talks about genetic, biomarker, phenotypic, psychosocial characteristics that will inform decisions about prevention, diagnosis, and treatment. And then you see along these other systems how they define precision medicine and share this kind of patient-specific, tailored customization, right? This idea that we need to think about the science behind how we match need and tailor need to services in order to achieve best outcomes. So when we talk about precision-based or personalized prevention, August and colleagues really have a lovely a lovely article in the special issue of Prevention Science in 2019 that talks about how we move toward a precision-based personalized framework for prevention science. And they talk about the individual, the what, the why, the how, and what's great about this paper is they really talk about group systems and communities when we're talking about personalized intervention. So how do we think about modifying prevention delivery systems? How do we think about instituting targeted policy? And via macro, environmental, or structural changes that vary across community or system. So often when we're thinking about precision medicine, we're thinking very individual. I showed you those other definitions, but there's also precision-based or personalized prevention that we need to be thinking more about at the community, systems, and group level. So this is my definition of precision justice, and I'm working on disseminating that in the field. But when I'm talking about precision justice today, I'm talking about bringing aspects of precision medicine to tailoring, optimizing, and expanding access to mental health and substance use prevention services for youth in contact with the legal and our child welfare systems. And, some ways in which precision medicine is being applied to youth, but very rarely with youth in the legal system, which is what YLS stands for, or foster youth, is in this area of genetic and biomarker studies. Very rare, if any, science happening with these young people in that space. Personalized interventions, that area is growing. Digital health tools, which we'll talk about today, data-driven decision-making, and collaborative models. And our team is really moving forward, and I know that's also happening here at Columbia, looking at this need for precision medicine to apply it across multiple ecological levels, right? So at the youth level, the family level, the communities, and the public systems that are in contact with them. And so the question is, what are we? And we is in quotes because you have to ask, who is the we? If you're really going to do community-led, systems-led work from the ground up, who is the we? And what are we asking that we to look at precision justice to address? So can or how, for example, can AI safely and effectively expand access to substance use and mental health prevention and treatment services within sectors serving publicly insured youth? So our approach is multi-pronged. We come from a very community engaged. I think we're really leading more toward community-led research and practice now. And by that, I mean those communities and those systems are actually telling us what we need to study. We bring an anti-racism in research approach and principles to our lab. I don't cite it here, but we've recently published in Health and Justice about applying principles of anti-racism in research specifically with youth involved in the legal system. Social justice is a core part of our mission, and everything that we do takes a health equity framework to it. And then the last piece, participatory co-design, which is a very specific approach to developing technological tools to advance care and access for young people. And I won't be able to talk about foster space today, but that is our co-designed tool for young people in the foster care system and was driven by a foster space advisory board that worked with us for 18 months from scratch to develop the intervention. Happy to talk more about that later. That study is underway right now to look at outcomes related to court-appointed special advocates who are one-to-one volunteers and how they are referring young people to use that app. But when we put this all together, we take these frameworks and we layer them onto eco-developmental theory. And when we're talking about going from individual, family, extrafamilial, and structural, so all those pieces that I was talking about before, we're thinking about how do these frameworks layer on to these different levels of eco-developmental theory, and how do we start thinking actually about not just doing one family-based intervention? How do we think about family-based intervention plus more macro policy and institutional level intervention, and how do those intersect? And so we rely on a framework called Tequity to kind of bring this all together. I did not develop Tequity at all. I borrow from scholars. And the Tequity for Health Coalition defines Tequity as the intentional design and deployment of technology, both to advance health equity and to avoid deepening existing systemic inequities and health disparities. It includes technology as well as data practices. And Clark did a really amazing job of bringing together social justice and anti-racism frameworks to Tequity, where the principles are that we invest in people and communities, that we are trustworthy, that we collect data that are relevant to diverse communities, and we keep it secure, and we make sure they understand how we are keeping it secure. We consider using AI and analytics to promote health equity, but I'm going to talk about some cautions with that. And that the purchasers of tech or the end users of tech must drive the change. That's key. So when I was talking about the Foster Space app, for example, and co-designing it, they drove all the change for that. And we participated with them, but they literally were driving the steering wheel in that process. Literally, figuratively, sorry. And then developing innovative partnerships that engage diverse communities, which I know Columbia and Dr. Elkington and many other colleagues' teams here are doing phenomenal work in that space as well. But we must really think about some cautions in doing this work. And this slide doesn't even do the cautions justice. We actually need a lot more research and research now in terms of cautions and or precautions, I should say, in thinking about how we leverage technology to increase access to behavioral health care for our most underserved and vulnerable populations. And so if you're not familiar with Ruha Benjamin, written many books, but one being Race After Technology. Ruha's at Princeton, I believe, and has done phenomenal scholarly work in thinking about technology and its impact on the carceral system and those who get involved come into contact with that system, and all of the extensive racial bias that enters into our technology and our algorithms. And this is where, in my opinion, AI can be quite scary, quite frankly, and this is why we need more research in this space, knowing that Black and Brown youth are absolutely disproportionately represented across the country still in staggering ways in the justice system, or the injustice system, as we call it in our lab. So, and then Design Justice is an amazing book, Community-Led Practices to Lead the World. So it's kind of combining that participatory co-design work and social justice. And then Dr. Vi Wright from the APA, who's the Senior Directorate of the Office of Healthcare Innovation, said I could borrow these in terms of challenges and threats of AI and mental health care that she raised, these issues of how biased input leads to biased output, the need to protect sensitive data, and the potential spread of misinformation and disinformation that we're seeing everywhere with technology. This issue of replacing and or changing human labor, when you are with the youth and the communities, they do not want human replacements, right? So this idea of how do we start to think about how the technologies can actually complement and increase access while not replacing humans. And then there's so much research that needs to be done about transparency and trust in AI. For example, in our field, I don't feel like we even have a sense of what level of trust young people who are in contact with the legal and child welfare systems even have around AI. I haven't seen any literature on that to date. I mean, we've got it's very nascent. So I'm just talking to all the trainees in here as well. If you have interest in that space, it is wide open and much needed. So when we're talking about participatory informatics, we're talking about community-partnered participatory research, right? So these frameworks that have been in existence for far longer than we've been doing this work, and user-centered design. So bringing those together. And when we're talking about digital divide, I'm not talking about who has a cell phone or not. Really, digital divide has really moved beyond that at this point to talk about that it's the ethical use of data and technologies involving consideration of who contributes to, benefits, and controls digital assets like data or software services. This is kind of a new digital divide emerging between those who benefit from the digital health advances more than others. So those who can create and maintain technology also are able to control what gets created. So this is why it is critical to consider who's able to actually create those digital technologies from the ground up. This is a smattering of our projects currently in the Juvenile Justice Behavioral Health Program. Unfortunately, I can't talk with you about them all today, but hoping I can have conversations about some foster space. CASA is the app that I mentioned, and that we're doing a large-scale implementation science trial across 12 counties in California to see if we train CASA volunteers who work one-to-one with foster youth, adolescents, if we train them in substance use prevention skills, communication, will they be more likely to actually refer young people to use this foster space app where they have a wide array of behavioral health services information and access for their particular county? And for those youth who do use it, will we see a reduction in substance use among those youth? So that trial has just started. So maybe I can come back and talk about that next time if you have me again. And then foster care family mental health navigator, I'm going to talk about. Family Telehealth Project is for youth who are separated from their families and sent all over the state of California. And it's a family-based intervention via telehealth that we started in COVID. I'm not going to talk about that today. Text 2, I will talk about, which is our text messaging intervention to enhance substance use treatment engagement for youth on probation. Project ECHO and the Youth Justice and Family Wellbeing Technology Collaborative. These are two systems structural level interventions. One, Project ECHO, is a telementoring intervention that we're now doing around the state of California to work with judges, attorneys, probation officers in developing skills and knowledge in trauma-informed systems approaches. So thinking about their built environment with their clients, thinking about communication with their clients in an trauma-informed way. And the Youth Justice and Family Wellbeing Technology Collaborative, we have a publication related to that was demonstrating that we could bring together a group of 15 to 20 professionals across child welfare, juvenile legal systems, schools, public health, behavioral health, public defender, district attorney, and they met on a monthly basis for 3 to 4 years, seeding as like a think tank. So this idea of systems-led research, they seeded, for example, the foster care family mental health navigator intervention that I'm going to talk about today. So, let's see. Okay, so those are the two we're going to talk about today. I don't know how much I need to get into background here. I think all of you in the work that you're doing at Columbia are very well aware that there are really high substance use and mental health treatment services needs for systems impacted youth, so juvenile legal and child welfare. Families, the literature shows that families are often unsupported. I was having a lovely conversation with Dr. Elkington this morning about how we think about caregiver engagement in the space with the youth and families with whom we work and the systems. And we continue to see gaps in access and continuity of care. And so we'll talk about that a little bit. Here's just a representation. Obviously, I think that you are all aware of, one out of every 7, so 14% of youth receive mental health treatment who need it in the juvenile legal system, and 1 out of every 10, so 10% of youth who need substance use treatment actually receive it on a national level. And so, and then here is work that has come out of the JJ Trials Collaborative that Columbia was a tremendous leader on. Dr. Wasserman and others, and Dr. Elkington, and our colleagues around the country. And what they looked at was, and developed as part of this NIHU collaborative, was this behavioral health services cascade. And what you're seeing here is a hypothetical illustration of unmet needs for youth under community juvenile justice supervision. But what you can see is they've identified these key points along the continuum of care, from intake, right, for substance use services all the way through to continuing care, where there are missed opportunities for identification, referral, and transition, and then retention in care. And actually, so the results of their trial, sorry, it's not cooperating. These are data that were from 33 agencies across 7 US states. So over 30,000 youth records that they did. I can't even imagine. This was like, every time I look at this paper, I think, wow, it's really, it's hugely impacted the field, this work. And so when we look at this, what we see is, let's see if my animation works. Okay, so what we see is that The systems are doing an okay job. They could be doing better of screening. It's about, I'm looking at the percent imputed data. So the striped bar, it's about 71% of youth who are getting screened for substance use service need. 58% of those were identified in need, but then you look from 58% of those identified in need, 27% are referred to services. And then you see another big nosedive happen when those who have initiated treatment, 30% drops down to 7% who are actually then engaged in treatment, right? So we've got these cliffs happening that JJ trials demonstrated that we need to start thinking about how to address from a services access perspective. So we had an NIMH 3-year, R34, in which we developed this model for child welfare, which actually didn't exist, and we adapted the cascade of care model for child welfare. And this was our kind of hypothetical, this was not our hypothetical model. This was actually, this cascade of care was hypothetical. This was not data-driven. So we kind of replicated what JJ Trials did. And we basically looked, and we had to change the steps for the cascade of care because the child welfare system screens and refers differently than the juvenile legal system, probation or diversion. So we had different, similar, but some different steps of the cascade of care. And we then we did a chart review with our local clinic in San Francisco City and County. So this is why it's much smaller N than 30,000. But it was the first look at cascade of care percentages for child welfare involved youth. And what you can see here, and we had to actually even tweak it a little bit further to meet the needs of the system and the steps, because you'll see things like CANS screener. That's the Child and Adolescent Needs and Strengths Assessment. That's the LION assessment. And that is statewide mandated for Medi-Cal youth, right? So we had to make some definite tweaks to the cascade of care according to how California sees these young people and moves them through services. But what you can see here is generally the same pattern. So 83% identified in need drops to 56% essentially referred. 33% had a full CANS completed, which means they got to the community and had a full assessment done. 24% had a treatment plan of care. And then we get down to 17% who actually received any services. And so you can see we went from 83% in need to 17% actually receiving services. We have a lot of work to do to think about this. And what you can see is how long, sorry, I missed my arrows aren't working. There we go. So these are the two spaces that we were really concerned about. And also, I don't know if you can see, but how many days from being identified in need to actually receiving services, you're looking at about 4 months minimum of going from being identified in need to getting services. We have a lot of work to do. So at the individual, youth, and family level, can we leverage technology to reduce some of these gaps with youth? So this is part of the R34 that I was mentioning, and we received funding to develop a foster care family mental health navigator model that would help to reduce the time between identifying need and getting young people to the services that they needed, as well as reducing the proportion of youth who didn't get referred, who didn't get to services, period. And we started right off the bat with our systems-led approach to have a champion stakeholder collaborative made up of many of those partners that I mentioned before in the technology collaborative. And we had direct youth and family input. And we co-designed this intervention with foster care mental health clinic staff. So these are BA level case managers. We had one licensed clinical social worker who was the supervisor, who was embedded in the clinic as well. And we co-designed this intervention with them. We did a small open trial. The randomized control trial was originally 80, 40 to each condition, which I'll talk about. We received this funding to start in March April 1st, 2020. So we all remember what we were doing. April 1st, 2020, it was the shutdown. So COVID. So I'll talk a little bit about where we ended up. So we were intent on, based on what the system staff were telling us, to develop a hybrid type of intervention, digital and in person. And through working together with the staff, we co-designed a 6-session intervention that really focused on orientation to specialty mental health services, really acclimating youth and caregiver to the system. How do I even get through the system? We'd have stories of families tell us, social worker says they're downstairs at the front door of my building. I don't even know what a social worker is, or who is this? Actually, is this a child protective services worker that came and took my kid away? Or is this actually someone who's going to help me, right? So we did clinical care team mapping, and barriers to care and stress management was a big focus that caregivers in particular wanted. We talked about therapy expectations and stigma. What is the difference between a psychologist and a psychiatrist? Things that we think youth and families would know, but they don't. And we ended with values and motivations to engage treatment, because the idea was over 9 weeks. So looking at the amount of time that it was currently taking to get them to services, that this intervention could be delivered in that period of time, and then they would be receiving services. And if we could shrink that time from referral to community-based services, great. We would continue to give them the 6 sessions. This was a dyadic intervention. Youth and caregiver had to attend. And then you'll see over here the Introducing Fostering Connections app. I'm going to talk about that briefly. It was an app designed to help them track appointment reminders, the navigator to communicate with them, and to support the cascade of care, their movement in the cascade of care. So just to give you a little sense of what, this was all PowerPoint driven, but very interactive. I had an extraordinarily talented clinical research coordinator who knew how to do PowerPoint very well and really created this beautiful interactive. They could click on these little areas and learn what the skill was. And so this was navigator-led through Zoom with the PowerPoint, or they could do it with a family if they were in person and use the computer. So they got both psychoeducation and skills. And this was the app. We built it with Chorus Technologies, whom we've partnered with in all of our apps. They take a participatory co-design approach. That is, they come from Ken Wells Group at UCLA, community-based participatory research, and have merged it with technology and the platform. And we co-designed this with the staff primarily and got feedback from the youth and caregiver. But basically, you can see here that this is acting almost like a my chart, if you will. At the time when we did this study, the San Francisco Department of Public Health in our city was not on the Epic system yet. They're on an old system called Avatar. There was no opportunity for any technology like this through MyChart. And so you'll see here, we tried to develop something that would show them their own cascade of care. Like, here's where you are at each step. So it would say here, you can look, you've been referred, right? So because there was no system or any sort of process for families to even know where they were in the cascade of care. Okay, so let's talk about the pilot trial. Yes, it did take 2 years to do the pilot trial. And we compared Foster Care Family Navigator, the 6-session intervention, plus 3 months of care coordination. So the full intervention, the active intervention that they got, they were with the family for 6 months, because that's what we were anticipating the time frame to be, unless we could shorten it, which was fine, but from being identified in need to receiving the actual care in the community. And we wanted to assess the feasibility, acceptability, and preliminary impact of that Foster Care Family Navigator intervention to usual care. And so usual care in the clinic was case management, but it was case management that involved, your kid's in need, here's your referral. That's it. Bye. So that was their standard of care. Not unlike many standard of care setups in clinics that are very under-resourced, very under-budgeted, and don't have much more with the high caseloads to be able to do. Due to recruitment challenges, and COVID, quite frankly, the revised sample size goal became 60 dyads, so 30 per condition. Randomization occurred at the dyadic family level, and we had up to 5 different navigators over the course of the study. So we had clinic staff, as well as we did have some trainees, but everyone who, except for the supervisor, was unlicensed. So just to show you very quickly our consort chart, you can see we actually were referred 198 youth and caregivers. We had 89 eligible. Eligibility criteria was not super strict. It was really if they were in need of intensive, right, or hospitalization services. And we did actually expand to include Spanish-speaking families. So that was great. So that was not an exclusion criteria. But we did have many other languages actually in the Bay Area, Cantonese, Mandarin, Arabic, Russian, that we had to exclude for. So, and then if they were in juvenile hall, if they were detained, they weren't eligible. They had to be in the community. So we ended up randomizing 38 caregivers and 45 youth. And the youth are more because we had caregivers who had multiple youth that they were foster parents for. And so we had 19 in the FCFN condition and 19 in the standard of care, and we assessed them at 1, 3, and 6 months. So I think I talked about this already, just to the intervention condition. Those were 6 60-minute intervention conditions. They happened in the first 3 months. And then they had these brief family check-ins and continued cross-system care collaboration. So they were in touch with them quite a bit in those months 4, 5, and 6. So if they dropped, let's say they got connected, but it wasn't a good fit, then the navigator was there to kind of pick up the pieces, support them, and find them care. And then I talked about the usual care condition. Our primary outcome here in our baseline 1, or in our 1, 3, and 6 month follow-up was to look at cascade of care services utilization rates. So we used EMR, electronic medical record data, to do that. And I just want to show you here, average age of the youth was about 14 years old. The majority were Latinx, 68%, and 45% male, 53% identified as female, 2% non-binary, genderqueer. There were no significant differences by condition on these demographics. The caregivers were on average 45 years old, and 94% identified as female, also majority Latinx. You'll see here that it says 50% birth child, 19% foster child, and 31% kinship care, which is when a relative takes care of a young person. The birth child was because from a prevention perspective, we did take in-home placements. So they were trying to keep the young person in the home and not have them be removed, but they were child welfare involved. And this is a low income sample. So 78% of families engaged in these navigation services. That is a tremendously high rate of engagement for this group of youth and families. They liked it. They liked it a lot. They found it very helpful. And the average number of sessions was 4 out of 6 sessions attended, 67%. Again, quite a high rate of attendance. So that was promising. And I just want to show you that the intervention was active in the way that we wanted it to be. So this is for youth frequency of contact with the navigator. On the left side is the active intervention. And what you can see is that they were in touch with their navigator quite a bit. On the right side is the case management, and above the orange/red line, you'll see there's very limited contact with the case manager. So our intervention was definitely different than the standard care case management. And below the orange line is, I have never talked to my case manager. So you can see how there was very limited contact in the comparison condition. And this is just showing you that the caregiver data look the same in terms of the frequency of navigator contact. So what did we find? Well, we actually found that we impacted the cascade of care. These are preliminary data. I can't emphasize enough. These are nascent in terms of the research, but exciting because it's one of the first pilot trials with this group of young people and a dyadic intervention, the caregiver level. And so what we found is the blue bar is the intervention line, and the control is the yellow line. And what we can see is all along the way that the intervention arm was higher in terms of the cascade of care steps. And if we look at the last bar, attended services, we achieved our goal, right? Which was that the intervention condition had 38% or so attending services, 39% versus 8% in the control condition. So we didn't see significant differences statistically, but it's trending really in the right direction, enough for us to think about how do we think about scaling the step to test with a much larger sample. So we detected these preliminary effects. We're going to explore secondary outcomes over time now by condition, looking at mental health symptoms, motivation to attend treatment. But again, we're very limited in terms of our sample size and what we can do in terms of looking at these secondary outcomes. We would like to determine utility moving forward of using the Fostering Connections app as part of a larger scale trial, because I will tell you that they didn't use the app too much. So we don't quite know. They felt it was clunky. It was, okay, we're talking about beta versions before you invest money in trials, right? To have these apps. The caregivers liked it. The navigators loved it. We did exit interviews with the navigators. The navigators loved it because they had an organizing system in the app to follow. So that could have actually impacted the outcomes as well. So we're looking at kind of next steps for this adjunctive technology piece. And these were some of the limitations. EMR data collection may not be feasible for large-scale trial unless they're on Epic, right? And we have other ways of obtaining these data. And resource to embed this model within clinics is limited due to resources. So there still was, though, a big gap in identifying need to referral. And we wanted to ask, could we actually think about reducing services engagement gap for youth in contact with the legal system? So now we've moved from child welfare to youth in the legal system. And we're thinking about texting as a low-cost, accessible method to support engagement, right? So brief SMS text messaging interventions been highly successful on the global health front, for example, in terms of HIV prevention and treatment adherence in Africa and other countries. But we've not actually tested how text messaging may be a low-cost accessible method to support engagement in treatment. So further down on this cascade of care for youth in the legal system. So we did a pilot trial where we had probation youth and caregivers receive text messages. Again, this dyadic approach, which many of our interventions are more youth-focused than family-based, even though family-based intervention for substance use and mental health for these young people is the standard of care when we're looking at improving youth substance use outcomes, for example. And they were randomized to receive dyadic motivational messages plus appointment reminders for their substance use treatment in the community, or only appointment reminders. So we use something called the Healthy SMS platform. Colleague Adrian Aguilera, who does a lot of digital health equity work with adult populations, developed this platform. So it's a UCSF, UC Berkeley kind of homegrown platform. Both conditions receive Monday, Friday appointment messages. For example, on Monday, are you planning to go to your appointments this week? And then on Friday, were you able to make it to your appointments this week? We'd ask them via text. And we had to do that. I'll explain some of our challenges, but because we could not access EMR data. So these are self-reported data of their treatment attendance. There are limitations to this, but we had to start somewhere. So the text to active condition, youth and caregiver receive Monday, Wednesday, Friday motivational messages based on the health belief model, and they also receive weekly tips regarding substance use psychoeducation. But again, the control condition only got the appointment reminders and the prompts about, do you have an appointment? Are you planning to attend? So health belief model, These are the domains above the I guess it's the lighter green, yellow lines. These are the areas, their perceived susceptibility, right? Their belief about the chances of experiencing a risk or getting a condition disease, all the way down to self-efficacy, their confidence in one's ability to take action. And we created these motivational messages, and we had a precursor pilot to this to working with the youth and caregiver about what type of messaging, like actually had them word the messages for us that you're seeing here. And then we used Canva to make content, and we have some Beyond videos. I see some smiles in the audience. You must be using Beyond as well, or Canva, or both. It's great, very user-friendly. And then we added these 2 domains below that aren't necessarily in the health belief model, but youth and caregivers said, we need more psychoeducation. They didn't use those words. They said, we need to know more about, like, is that drug harmful? Like, how does my kid find that drug? And also stigma reduction. And so for stigma reduction, an example of a message might be for your teen, it might feel like no one understands what they're going through, but did you know 1 in 16 say mental health or substance use cause problems in their life? The good news is that there are solutions that work. These are other examples of kind of what the text messages looked like. We have a little Beyond video here, but I'm not going to play, I don't think. Yeah, so they get their message of the day. So we tried to make it, engaging. These are examples for the youth. Actually, Dr. Elkington and I were talking yesterday about one of our projects about the money that you spend on substances, right? They don't realize that. So actually, one of our psychoed messages was, money spent on substances equals less money investing in your future. Let's see. Okay. So we had multiple challenges here again, too. Remember, I said not a tale of perfection here. So referral rates were less than 5% in our partnering county. And so we partnered with 2 other sites, actually, in other states, and referral rates were still very low, referral rates to substance use treatment. And so that gap, that nosedive that we were talking about was really reflected here, which makes it very challenging to then recruit enough youth and caregivers to deliver a text messaging intervention aimed at enhancing the likelihood that they'll go to the treatment that they were referred to. So we expanded to a national online sampling frame. We moved to a self-referral model and self-reported attendance, like I was mentioning. We ended up with excessive numbers of youth ineligible using this method. And if anybody wants to talk to me about scammers using online methods for recruitment, we have many lessons learned, and we joke about the clinical research coordinators becoming a different type of PI, like different type than principal investigator, because we really had to do a lot of detective work. We had to work really closely with our IRB to ensure that we were ethically withdrawing people whom we suspected were scamming. So for gift cards, 392 screened, 74% were eligible, 20% eligibility rate. And we baselined 34% of those 74 that agreed to do it, to do the trial. And we ended up with 12 dyads in the active condition and 13 dyads. So 24 participants in the active condition and 26 in the control. And this just gives you a sense of the majority, when we asked about planning to attend for caregivers and teens, I just wanted to show you here that the majority of these participants said, yes, we definitely plan to attend. It's 90% upwards of the participants saying, I have an appointment and I plan to attend. So I am, a little skeptical about our sample in terms of self-selection bias, right? But we're learning here. And then when we look at, were you able to make it to your appointment? We see that and so this says 350. I just want to make sure you understand those are data points, right? So that's for every single message that we sent. That's not participants. So out of the total number of were you able to make it questions that were asked, 84% said, yes, planning to attend. And youth and caregiver were really aligned, which was really interesting. They get their messages separately. I thought that was really interesting. So youth and caregiver in these dyads. So again, thinking about who are these dyads that are participating, and And then when we look at 90-day treatment attendance by condition using self-report, we see that the mean proportion of attended sessions was 94 to 95% of attending sessions. So this is not like our most typical sample, and we think we might have hit like a ceiling effect here potentially. High rates of planned attendance equals high attendance, right? We know there's a possible priming and intention effect there, but that's interesting, right? Like maybe is it that we're asking them, were you planning to attend? So now they're primed and they actually do end up attending. We weren't intending, how many times can I say intending to have that effect, but maybe that's part of what's going on. It could be that appointment reminders were too active for the control condition. So maybe appointment reminders are sufficient. And we know that's true in the healthcare system, that appointment reminders are incredibly helpful, and we don't have these technologies standardized for young people in the legal system and child welfare system, and they're so burdened with appointments. Or is this a ceiling effect? The bottom line is that referrals to substance use treatment are extraordinarily low, which is what JJ Trials also found nationally, despite high substance use treatment need, and we need an intervention to enhance referrals for youth in need. So here's our systems piece, reality check. Few juvenile legal or child welfare systems use reminders. This is a lost opportunity for youth and family engagement. So thinking about the things that the systems and the youth and families all at the same time would see as helpful to them. Those are opportunities for engagement and to improve outcomes. And the third thing, what do we do about referrals? So let's go back to our precision medicine and think about how we might think about applying precision medicine and at the systems level and the youth and family level. So in red are kind of the three areas that our team is focusing on now and thinking about next steps given these trial findings, these pilot trial findings. So the use of digital health tools, data-driven decision-making, so in the systems, and Dr. Elkington's doing tremendous work on that with their eConnect project, with probation officers, and collaborative models, which is baked into really everything we do. I hope you can see by now, and how critical that is. So let's go back to this JJ Trials model. We asked how might we use technology to increase the rate of referrals for youth in need at the systems level. And JPO here stands for Juvenile Probation Officer. So we have not looked to see what we could do potentially to expand their going from need, where they screen for mental health and substance use for the young people that come into contact with them as part of their caseload, to referral to community-based care. Meaning we in California, I'll just say. And so JJ Trials actually look to see, why do we see this mismatch of need to referral rates? Danica Knight, who I also have the great pleasure of working with, who's phenomenal at Texas Christian University, as part of the JJ Trials group, they found that probation staff perceive referrals for substance use treatment as less important. And there's less probation supervisor encouragement of these referrals. And that was those were a large portion of the reasons why they saw the nosedive from need to referral in the large scale trial that I showed you. And we found in our qualitative work with probation officers that probation staff and agency have the perception that treatment is unavailable when it actually is available. So we've had open slots in our clinic, and we are being told that youth are in need, but huge chasm in referring, even though they have the information, even though we meet with them. Something's going on there. So our current NIDA project is focusing on looking at something called nudge theory. And this is where AI and large language models can come in to play in terms of thinking about how we transform system services access. So how many of you have heard of nudge theory before? Okay, great. So nudge theory is increasingly informing system and staff level interventions to improve public services, right? Like I said, within the healthcare system. And it's based on concepts drawn from the field of behavioral economics and cognitive psychology. It posits that people's choices and behaviors can be influenced through small suggestions and positive reinforcement that are low cost. And so central to nudge theory is allowing individuals to pursue any decisions they wish, so not forbidding any choice options. And nudges don't operate as mandates for decision making. So if any of you have worked in these public services, particularly in the juvenile legal space, it is very mandate focused. It's very top down. You have to do this way. Nudge theory actually changes the architecture of the workflow and the workforce environment, and it focuses on the design of choice environments that facilitate personally and socially desirable decisions without restricting people in their freedom of choice. So results from nudge trials done with different types of healthcare providers like pharmacists, nurses, physicians show promise in, for example, improving vaccine uptake. They put little nudges in the EMR system to nursing staff, say, did you ask your patient for if they're up to date with their vaccines? Just that one piece when they were going to chart, getting that nudge dramatically improved vaccine uptake, right? So we're thinking now about how to think about the built environment of juvenile probation officers' workflow and how we might actually think about testing a nudge intervention to increase rates of referral for young people in need. And so this is just an example of a framework that we're using, 3 steps to co-design a nudge practice for probation officers, where we identify the target behavior, and then we identify what they call the friction and fuel of the behavior, and we design and implement the nudge using this EAST framework. So basically, we're going to go through a behavioral process map with our juvenile probation stakeholders. We're working with the Office of Youth Community Restoration in the state of California, which is the body overseeing health under Health and Human Services, or Department of Healthcare Services in California, that's overseeing all of our juvenile probation across 58 counties. And we're going to work with that office and juvenile probation staff to do a behavioral process map to actually understand what's happening in terms of their screening, identify their cascade of care currently. And we're looking to replicate the survey that JJ Trials did nationally with 58 counties in California to understand this. And from there, I have a consultant who's actually part of Humu, which is a nudge theory tech company that has been successfully looking at how we incorporate these nudges within existing built work environments. And we have to design the messages within this EAST framework according to the prior literature, showing that if you make the messages easy, attractive, social, and timely, and by social we mean presenting the social norm, then we're able to get those nudges in and potentially see behavioral change. So I just went over this. So our next steps for this trial, I don't have data yet. We just were able to start this in August. Yes, we're in October, August. So years 1 to 2 are this partnership that I was talking about, and then years 3 to 4 are to pilot an efficacy trial with 100 probation officers across California to see if we can actually move the needle on this referral. And this is where we start to think about the use of AI, right? These nudge messages are actually going to use large language models to actually push out the nudge messages. And we're thinking about ways to use generative AI, right? So depending on how the probation officers respond to those nudge messages, developing other nudge messages, do we back off? How are they approaching this? And have it be tailored, because each of our counties are also so different in their practices and their people. So we want to think about use of AI to improve referral triage, like we were just talking about, but also to think about system decision support even further down the cascade of care, and most importantly, mental health and substance use services matching. So how do we think about these nudges to actually help probation officers feel like they have a choice in the matter, but you're nudging them along to understand that it is critical to match need to service type to have best outcomes for their young people. So looking forward to taking questions and talking with all of you. Thank you.